Welcome to the Senior Rehab Podcast,
the podcast for rehab clinicians that want to better serve older adults.
And now, your host, Dustin Jones.
Hello, friends. Welcome to the Senior Rehab Podcast, and thank you for tuning back in this week as I'm going to finish up my conversation with Dr. Jason Falvey and Dr. Kyle Ridgeway on You Can Reduce Hospital Readmissions. So we basically dive deep into their recent publication in the Physical Therapy Journal titled Role of Physical Therapists in Reducing Hospital Readmissions, Optimizing Outcomes for Older Adults During Care Transitions from Hospital to Community. If you have not listened to part one, I highly recommend you go and do that before you listen to this episode. We pick right up where we left off, where Jason cut off his internet and went and got another beer. And now he's back and ready to dive into the rest of this article and really wrap up this topic of how we can have a dramatic impact in reducing hospital readmissions. Let's do this. You got your refill? You got your beer?
We just emptied, actually.
Yeah.
All right.
Yep.
So we were at enlisting help of social and community supports.
Okay, perfect. So enlisting help of social and community supports is one of those things that PT shares with other professions, nursing and social work. But it's an important area because if you send somebody home from a hospital with an unmet need for ADL assistance, be that bathing, eating, getting out and getting groceries, etc., they have a 66% increase in the odds of hospital readmission compared to older adults who are at a very same functional level, but they have all their needs met, either by a caregiver or other social support.
Did you say 66%?
66% increase.
My gosh. All right, sorry. Keep going.
Yeah, so that's striking to me that, so functional level like muscle strength and aerobic capacity, those things are kind of independent of just having the amount of help that you need. So acute care PTs or home health PTs really have a role in helping prevent some of these readmissions because they can collaborate with social work and make sure that needs are in place. They can communicate with social support providers. Maybe it's a family member making sure they know how to appropriately care for the needs, a daughter that's coming into town. Maybe that's making sure that Meals on Wheels is able to come to their house and helping patients set that up or showing them independence. And a lot of PTs are going to say, that's not my job. That's the job of the social worker. But sometimes PTs really need to take a role in this, not just to do the responsibility of, of getting these ADL set up, but also making sure that they, lost my train of thought there, but making sure that they're doing the right education, right?
Yeah.
So let's think about the home health PT who comes in, sees that a patient is not able to go out and get their groceries. That PT could refer to social work who takes 3 or 4 more days to get out there, evaluate, and get it set up. Or that PT could make a phone call out to the Meals on Wheels provider. And you're probably improving functional outcomes by making sure that happens.
I'm going to remember that next time because I definitely take the lazy route and say, the social worker will take care of that. I need to link that to functional outcomes. What would you say to that, Kyle Ridgeway, in terms of the enlisting help of social and community support? You mentioned the social support aspect in terms of opportunity for education, but do you have anything else to add to that?
Yeah, and I think most acute care therapists are kind of implicitly very good at this just over time, but we don't think about the profound nature of actually engaging and assessing and how the patient's social support and social environment and how important that is. And the example I use with our PT interns all the time is, okay, you measure a patient's function in a vacuum, right? And you have Mr. Smith, and he can walk 100 feet, but he needs some supervision, and he's a pretty high fall risk based on balance testing. And you have Mrs. Smith, and she looks the exact same functionally. But the factor that's different is their social support.
Yeah.
Mrs. Smith lives with 3 family members. She has 24-hour assistants. Those people are engaged in her care plan, and they can actually take care of her. And then you have the other social scenario where they cannot. And that's a very, very obvious example. But the more profound example is how do you engage their social supports and connect them with community resources that can really set them up for success so that patient can go home. This is the thing that I think as acute care therapists we need to be much more, I don't want to say thoughtful about, but we really need to start digging into the details. And the question we should always ask ourselves is, what would it take to get this patient home? Because especially for older adults and anyone who has a cognitive impairment, even if it's mild, those patients may not do very well in other levels of care for prolonged periods of time. Especially you take someone with dementia, you take them out of their home environment. It's always going to be worse. So sending them to a SNF, to a subacute rehab, may actually not be the best plan for them. So we have to look at what are the community resources, what's the social support that we can engage and enlist to actually get this patient home. What can we rally around this patient to get them home? And there's already models of care like this where, there's programs where they do everything they can to keep the patient in the home and give them care in the home. And I think acutely we need to be much more disciplined about saying and asking the team and ourselves and the family, is it gonna take? What do we need to rally? What do we need to set up to get this patient home? And that's sometimes in a complicated situation can take a lot of time and conversations because you're talking to a physician, you're talking to nurses, you're talking to social workers and case managers and thinking about community programs. And again, in the acute care environment, that's going to be as seen or measured as not a productive time, but to the patient and to outcomes, that's remarkably productive.
Right.
If you can get that patient, even if it's only 20%, some arbitrary number, and avoid a SNF admission, and get them home with the proper support, that's a really, really successfal outcome.
Yeah. And to add one thing, like I found my train of thought that I lost a couple of minutes ago. One of the other pieces that I've talked to some therapists about as part of another formal study is recommendations for durable medical equipment. They're often made in the hospital settings for tub benches or other equipment to really meet those ADL needs. But rarely are physical therapists in the acute care setting afforded the opportunity to follow up on those recommendations and call a patient afterwards and say, hey, were you able to get this equipment or help coordinate those things?
Yeah.
And that is no fault of the acute care therapist. That is not considered productive time for them based on a high percentage of the national survey that we just did that's going to be coming out soon. So I think things like durable medical equipment, when you think about home health, we often say, well, Medicare doesn't cover that, but knowing other community resources that might provide those things for free or on loan, I think is the responsibility of a PT because it's such a critical role to prevent hospital readmissions.
Yeah. I will completely agree with you from my home health perspective on that for sure. Jason, can you speak to advanced care planning?
Yeah, so advanced care planning, what has been termed as death panels previous to some of these discussions in other political circles, is a really critical part of care for older adults. And traditionally, that is a place where physical therapists haven't had a seat at the table. Yeah. Advanced care planning, for people who may not be familiar, is looking at, do you want a DNR, do not resuscitate order? Who's going to be your medical power of attorney in different positions? Would you want to do a hospice or palliative care for conditions that are potentially terminal or may not be something that can be medically rehabilitated very easily? So that's often led by physicians, and appropriately so. Nurses are often highly involved in that process. I would say that physical therapists have a role because advanced care planning and getting people on hospice and palliative care is usually a decision that enhances quality of life. One of the problems with getting on hospice or advanced care planning is a lot of patients have functional limitations such as falls or inability to transfer, inability to perform bed mobility that really do limit their quality of life or ability to age at home or live comfortably at home. Or they fall and have injuries that end up having them and spend the last weeks of their life in a hospital with a hip fracture while they're frail and debilitated.
Yeah.
So PTs may be a good advocate for palliative or hospice teams to really make sure that we can advocate that PT is not just a restorative role. PT can have a maintenance role that can prevent unavoidable hospital readmissions for this hospice population, where a fall that results in a hip fracture, there's no way that person can stay at home. But a PT could be involved early in that process, teach the transfer techniques, and perhaps prevent that fall and allow that patient to die at home or be able to be around their family.
Mm-hmm.
Not a role that, is a sexy role for PT, is a maintenance or, slowing of decline or allowing somebody to die in their own bed. But I think it's critically important and something that's kind of undervalued in these care transition pieces, because it's a huge source of readmissions and what I would consider avoidable readmissions.
Mm.
And I think Dr. Ridgeway had something to add there too.
Yeah, definitely.
This is actually a topic that is really that I'm actually really passionate about. There's not a lot of forums to actually talk about it. I'm really glad that we brought it up in this manuscript. And just as some background, currently I work only in a medical ICU and help coordinate therapy services and some quality improvement out of that unit. And that's a unit that, if you just look around the nation at any hospital, that's going to be the unit that has the highest mortality rate. I can tell you that at our institution, 1 out of 6 to 1 out of 7 of every patient that is admitted to our medical ICU is going to die in our medical ICU. So we have a really high mortality rate. And, one thing that we do know from Medicare older adult data is the rate of invasive procedures and tests infinitely increases in the last year of life. And again, we've been so lucky at our institution that our palliative care team is really, really seeking out the assessments and recommendations and insight of the physical therapist. And in our medical ICU, because of the way that we're integrated in that unit, we actually sit in on a lot of family meetings.
That's awesome.
And what I can say just from observation and what my sense is, and I think the data in the long term is going to flesh this out, is that despite medical prognosis, or even regardless of medical prognosis, functional prognosis is just as important to making these care decisions. And as I spoke to earlier, there's going to become a point that our physician colleagues, our palliative care team colleagues, demand from us what the functional prognosis is for some of these patients, because that's going to help the patients and family make decisions.
Yeah.
Because when I sit in on these meetings, the patients, they don't care about the physiology. They don't care about how reversible is my stage 4 cancer. How reversible is my end-stage heart failure? What they care about is, how am I going to function? What symptoms am I going to have? And what can I do? And so many times what my physician colleagues are asking me and my team, and especially our palliative care team, is, what's a realistic functional goal for this person if they're even able to engage in active kind of restorative rehabilitation? And many times patients and families are making the decision based on the fact that, hey, you know what? We've been working really hard with your mom, and for 3 weeks, she hasn't made any progress, and she has a really high symptom burden whenever we try things, and that's the limiting factor for her. And we know that she doesn't want to do that, so I think it's really unrealistic to think she's going to be able to do treatments for us.
Yeah.
So maybe inpatient hospice is a better decision. And to Jason's point about equipment and reducing readmissions when someone makes these decisions, is our palliative care team really looks to us to say, what type of equipment do we need to set up for this person to get them home? Because their goal is to actually spend their last days at home. How do we make that happen? And to Jason's point, it's not something that's sexy, and I think it's not something we talk a lot about in PT, but we have a really, really big role and can contribute a lot of value to advanced care planning.
Mm-hmm.
But beyond that, we can also contribute a lot treatment-wise. If you talk about quality of life, maintaining your functional status, or even slowing the decline of your functional status. I mean, I can't tell you how many patients we've had where they are going to go end of life. They are hospice. They are going to go home with hospice, maybe even. And we are able to get that person just into a wheelchair and get them outside. Mm-hmm. And I got to tell you, there's no data that can convince me that that's not the right thing for the patient, for the family. And those moments are really special and really convince me that we should really transition more, or not transition more, but really be stronger advocates in wanting to take on these roles. And unfortunately, because of different payment models and things like that, we have to prove that patients make progress.
Yeah.
And I think that we can actually talk about, what does palliative physical therapy look like? And should that look like? And I know I've really digressed there for a long period of time, but I really, really think that this is an important and innovative kind of subtopic that we should all think about.
Yeah, I mean, I would agree with you, especially from the home health perspective. Cindy Kraft she's a former home health section president, and she made the statement or posed the question, are we addicted to progress? And that we discharge so many patients based on lack of progress when there is verbiage, I guess, in the Medicare guidelines that allows for maintenance therapy. And for anyone that is interested in maintenance therapy or doesn't know a lot about it, I highly encourage you to listen to the interview I did with Dee Cornetti. She's a current home health section president, and she really dives into this topic of maintenance therapy, because I know, for me being a home health PT, it's something I deal with on a day-to-day basis in terms of when to discharge, or should I even discharge, or transition this person to a maintenance type role or program. And she addressed that pretty well. Kyle, you mentioned your physician colleagues, and having a seat at the table when you're talking advanced care planning. The next section in the model was coordinating care among team members, and you all mentioned the situational background assessment recommendation. Could you tell us more about that? I'm not too familiar with that document.
Yeah, so this is basically just a model of communication to help focus people when they're communicating kind of critical information, or especially when they're communicating a status change in a patient or handing off care for the patient. So at our institution, this is kind of the standard template for communication. And this is even how we propose programs. Like you should send, we call it an SBAR. But there are other models out there. But basically, what we're getting at here is that when we're coordinating communication and care among different team members, is we probably want to have a template for how we present that information. The situation background assessment recommendation model basically says, if I'm going to come to one of my physician colleagues because I found something that's new or different, or I need to communicate a recommendation, that, the first thing I say is, what is the situation? The situation is, I want to talk to you about Mr. Smith. He's in room 1075. And I want to talk to you about his discharge plan. And then the background is, just to get you up to speed, this is a 75-year-old gentleman who's admitted with a COPD exacerbation. He has a 4-liter baseline O2 requirement. He's been needing 10 liters while he's been here with this unit. My assessment is that he really does not have any cardiopulmonary reserve. For example, we tried to get up and mobilize today, and we had to up his oxygen and actually give him another oxygen device just to actually transfer to the chair. It took him 5 minutes to recover. So I'm really kind of concerned about his oxygen demand with activity, and my recommendation is that we actually keep him here in the ICU or in the hospital, whatever it may be, for a couple more days. And I'm not confident that he's going to be able to discharge him. And that's really my recommendation. So it kind of gives a structure to the conversation, which I think is good, because especially for therapists, we have a tendency to be if we're going to look in the mirror and be constructive to ourselves, we have a tendency to be a bit long-winded and write in paragraphs and speak very verbosely about things, and not speak the language of our colleagues, and use words that are maybe only salient to our own profession, and sometimes the theme of things is lost. And so I think that the more that all disciplines rally around a central way of communicating, it makes things more efficient, but it also ensures that there's more clarity.
Yeah.
Because there's a lot of team members at the table for a patient's care. We all need to be able to come to the table and understand what the other people are saying, so that when I say a word, the physician knows what that means, but that also that the coordination for the patient, who should be at the middle of the conversation, actually happens.
Right.
And that's really the tenet of transdisciplinary care. The patient's at the middle, and we're all working towards the goals for that patient, even though there may be overlap between who does what, and so then certain people own different things. So it's really just a way to both streamline and standardize the way that we communicate, to decrease miscommunications, but also improve understanding. And I found it, it's one of those things you look at, like, this is kind of corny.
Yeah.
We're all professionals. We can talk about this stuff. But I'm going to be honest with you, when you really stick to it, it really does help things, because people are now forced to talk to these kind of four kind of constructs, and it focuses the conversation so that it's not a long-winded conversation and both people have a lot of questions and no one knows what anyone's talking about.
Right.
And I think you don't have to use this template, but you got to develop a standardized template so that communication breakdowns don't happen, but that also that communication is received and then implemented and actionable. Because communicating something is important, but then it's the recommendation, right? It's that those steps that are recommended are worked towards.
Is this within your EMR?
It's not within our EMR, but this is kind of the standardized way we're trained to, like, if I return a page, or if I'm talking to someone, or if I'm emailing someone about something, this is the format that I should take to communicate information and situations.
Okay.
So interestingly, while I find it ironic that Kyle is talking about being long-winded and how that might be a detriment to the physical therapy practice, I do.
It's the beer, Jason. It's the beer.
I do agree with many of his points. So one of the things I wanted to add in with there is the idea of continuity after hospital discharge. So with providers. So the best case scenario for most patients, like in home health, the literature shows that patients who have the highest degree of provider continuity, being treated by the same provider over a period of time after a hospitalization or in a home health episode of care, they tend to have the highest functional outcomes. They tend to have better functional outcomes than people that have lower amount of provider continuity, being treated by multiple therapists or a therapist PTA, and not really having the same voice every time. So I really think that speaks to having strong communication across the settings. And the more hands that are in the pot of treating a patient, the better the communication has to be. And it's like a game of telephone. And if you talk like Kyle Ridgeway, that game of telephone can get very tedious. But having his suggestions in that long-winded diatribe that he went on were very good, in that we should have short, brief, to-the-point communications between providers that really tell you the critical, important pieces for treating that patient.
You know he's going to spit in your beer when you go use the bathroom, Jason, right?
My beer's empty. I'm all safe here.
Verbosity is both a skill and a limitation. So.
Yes. I'll second that.
Dr. Ridgeway lives by the philosophy, brevity is beautiful.
Yes.
And I'll just leave it at that.
So, Jason, Mr. Home Health PT, talk to us about the next section, monitoring and managing symptoms after discharge. And just to give listeners an idea, we've got this section, and the last one is outpatient follow-up. So we're chugging through this. So let's talk about monitoring and managing symptoms.
Yes, and I have to thank your audience for being patient as we go through all of these things. Both Dr. Ridgeway and I are pretty loquacious in how we approach these things, but I think a lot of this stuff is really important and stuff that is under thought about. So thanks to your audience for sticking with us.
Yes.
So monitoring and managing symptoms is a critical role across most of these care transition programs that exist, right? So you think about heart failure, for example. Every patient and their caregivers are quizzed repeatedly on if you gain 3 to 5 pounds of weight over a certain period of time, you need to call that doctor. That is a bad thing, or you need to take this medication. They need to weigh themselves every day. There is very handout and color coding and everything to really push those patients to be thinking about those things. Monitoring and managing symptoms, as we talked about, doesn't always extend to physical function. And I find that a really concerning omission given the high volume and high quality of the literature that suggests that physical function is perhaps one of the strongest predictors of readmission, more so than comorbidity status, more so than medical condition, more so than cognitive status. If you look at the literature, it's mixed, but function consistently comes out as one of the strongest predictors. Yet, when you talk about monitoring and managing symptoms after discharge, there's very little formal education, written education that is given to patients about how to monitor and manage their own function. Things that should be communicated not just to patients, but to other providers. So a physical therapist that's in the hospital that sees a functional deficit needs to be communicating that deficit to the care transition team, to the patient's physician in some way, shape, or form, so that can be followed up on and known about. Other pieces of monitoring and managing symptoms is that physical therapy consultation is considered kind of an add-on bonus to care transitions, not an integral part. And I think that's a major limitation given that we are the experts in managing function.
Right. Do you see technology streamlining this process in terms of monitoring symptoms or function?
Yes, absolutely. I think that's a great question, and one that I recently talked about at CSM with the technology special interest group people. And while this technology, specifically wearable technology such as a Fitbit, is in its infancy, I think there's a huge role for this kind of technology in teaching patients to self-monitor. Something like physical activity, like we've mentioned earlier, is a huge risk factor for hospital readmissions when people are walking under a certain number of steps per day. Yet it's rarely monitored in a way that's both objective and patient friendly, and something that is continuous feedback for patients. A Fitbit provides all of those things where you can educate them that they need to walk at least X number of steps per day, and you can remotely monitor that. And if you're not scheduled to follow up with that patient for a week, but you see over the last 3 days that they've had a progressive decline in ambulatory ability, maybe that prompts you to call or make an impromptu visit to that patient's house and check in on them. And maybe they're fine, they've forgotten to put it on, or maybe they have a urinary tract infection that has been untreated and you're catching it before it turns into sepsis and an ICU hospitalization.
Yeah, I was there for your talk, and the data that you presented was amazing to see the correlations that you had just from having your patients wear that Fitbit. Kyle, do you have anything to add to monitoring and managing symptoms?
Yeah, I mean, I think this is something, again, that physical therapists are really used to engaging with, and that other providers may not see in the way that we see. And what I mean by that is not many other providers are mobilizing the patients or having them do activities, or even kind of, nudging the patient or requesting of them to do things that they normally wouldn't do. And so I think really we have to own the monitoring and communication of symptoms in regards to movement and mobility and physical function, because no one else is. Because we're going to be the ones who actually see this as it's happening. The person who has really, really acute limiting pain affecting how they move around. The person who has really, really severe dizziness with or without vital signs changes. The person who has a lot of fatigue on exertion. The person who has a lot of dyspnea on exertion. These are really important things that don't manifest or don't unmask themselves sometimes until we ask the patient to move or exert themselves or function. And again, with my acute care lens, this is something that needs to start early in the patient's hospitalization, is actually looking at what are their symptoms both at rest and with activity and during recovery, and engaging the team to proactively assess and maybe medically treat those symptoms, but also really kind of grabbing onto the symptoms that we can treat, whether that's pain or shortness of breath or fatigue, and interfacing with those symptoms and giving patients a way to tie it back previously in the manuscript to self-manage and to self-monitor and to communicate with their other care providers. So I think it's something that is salient from the time the patient's admitted all the way until they see maybe an outpatient physical therapist, right?
Yeah.
And if you talk about outpatient physical therapy, that's what they deal with mostly, is patients who come to them with, I have this symptom, right? And we need to kind of be better about that, I think, maybe in acute care and home health, really learn from our outpatient colleagues in that regard.
Yeah. So I think that's a good segue to the last section, outpatient follow-up. So Kyle, I'll let you tackle that one first and let Jason come in with anything else to add.
Yeah, this is one that is really important from our medical colleagues' standpoint and physician colleagues' standpoint, in that primary care or outpatient follow-up can be not timely and can sometimes be incomplete because of all the reasons that we've talked about. But furthermore, is that physical function is rarely assessed and rarely discussed at these follow-up appointments with primary care physicians. And then I would say, from my standpoint as an acute care therapist, I think, when I worked in acute care and outpatient at the same time, the thing that I always got to see the paradox between the two settings. And what I always noticed is, like, man, we really, really under-refer hospitalized adults to outpatient physical therapy, number one. But number two is that if someone's been hospitalized, they need to have outpatient follow-up, but they need to have outpatient follow-up where someone actually looks at their physical function and is looking at that as a really, really important thing, and then making decisions on whether or not that patient actually needs more rehabilitation intervention. Because there's going to be a lot of patients, a lot of older adults even, who are discharged from the hospital with minimal contact with an acute care therapist, no home health, and no outpatient therapy. And so if we engage in these care transition models, we can educate our nurse and physician colleagues on really basic ways for them to screen physical function from a physical performance standpoint and screen physical function from a patient report standpoint, and refer the patients early and often who maybe actually need more physical therapy follow-up in an outpatient regard. So I think there's a role for all three of our acute care, home health, and our outpatient colleagues to really capture and add a lot of meaningful interaction for hospitalized population.
Yeah. What say you, Jason?
Yeah. So, I definitely agree with everything Kyle just said. And I think it's really important for us to educate physicians, nurses, and to remember ourselves that declining physical function occurs in isolation of disease severity. So somebody can have stable heart failure that looks like it's doing really well, but they can have a pretty significant decline in physical function that, if it's not specifically addressed, a 0.1 meter per second gait speed decline is clinically meaningful and very prognostic of future poor health outcomes. Yet it often is silent if they have independence with ADLs and their heart failure or other medical situations stay stable in an outpatient setting. So it's really important for physical therapists to maybe educate physicians on which tools, which tests are best suited for evaluating patients after hospitalization and getting together some sort of battery. Like we talked about, declining physical function after hospitalization is incredibly prognostic of poor outcomes like readmission or death. And if a physician is the only point of contact for a patient who is perhaps referred to outpatient but can't access it, or doesn't qualify for home health, or refuses those services, I think it's really important to know that there's a physical function assessment that is in their future that can really help identify people that are at risk.
Yeah, that's a good point. And that wraps up all these steps. My gosh, we made it through. So let's go through these one more time. Discharge planning, complete communication of information, availability, timeliness, clarity, and organization of information, medication safety, education of patients to promote self-management, enlisting help of social and community supports, advanced care planning, coordinating care among team members, monitoring and managing symptoms after discharge, and then, like Jason and Kyle spoke to, the outpatient follow-up. So we've hit these transitions from every possible angle, and as the listeners can definitely tell, physical therapy has a seat at the table in all these different areas. So we've covered a ton in this episode and the previous one as well, which I'm very thankful for you all expanding on a lot of these things that you talk about in your article. But I want to ask you both one more question, and I'm going to start with Kyle. For the acute care physical therapist, the skilled nursing facility PT, or the rehab hospital PT, and we'll just throw in all the therapies in there, people that are making their recommendations. What is the one thing that you would recommend they do tomorrow to improve this transitional situation that we've been talking about?
I think if I had to say one thing, it's talk with your colleagues. And I don't care if that's your therapy colleagues, your nursing colleagues, your physician colleagues. We got to get physical function and physical performance on the radar screen of all providers, not just as an important thing to do as an intervention, but as an important thing to measure, to talk about, and to track over time. Because as Jason mentioned, it's not just absolute physical function or performance in a vacuum, it's the trajectory of that. Is it getting better? Is it getting worse? And how quickly? Yeah. And I would say subsequently, because I'll never be short-winded in the answer, is I think we need to have a really, really, really remarkably low threshold to recommend home therapy services.
Yeah.
I mean, if it even pops in your mind, you should just recommend it.
Yeah.
And I think as bundled payment and as different payment models come up, the incentive and the growth of this for both acute care therapist involvement in patient cases and home health therapist involvement in patient care is just going to explode.
Yeah.
And so I think the future is bright. We need to look at things from a lens and communicate things that we're not normally incentivized or expected to communicate and talk about.
Right. So communication. So Jason, let's think of the home health or the outpatient therapist. What's the one thing they can do tomorrow to improve the transitions in healthcare?
So I would say that those therapists really need to start thinking outside of their silos of healthcare. So this is one of those situations that's been described by physicians that different healthcare settings are silos. They're separate, distinct buildings that don't really have crosswalks or communication set up between them. And I think home health, outpatient physical therapists really need to, not take their blinders off. That sounds, kind of condescending, but they really need to think outside of their own personal setting and not be afraid to set up communications with the acute care hospital, with outpatient therapists if they're referring, one direction or the other, and trying to make sure that the communication gaps are closed for these patients, to make sure that trajectory of function is monitored throughout, to make sure that there's really clear communication about functional goals and abilities, and clear communication about the best way to approach patients. And one thing that I've really heard from therapists when I've interviewed them is that nuances such as the best way to educate or motivate a patient are often lost between care settings, which I think is incredibly valuable information that never gets written in a chart. You can't write that Mr. Jones is a cantankerous asshole in the morning, but he really participates with me in the afternoon, right? You can't write that in a chart, but you can eat. Right? But you could talk about these things in an oral communication, a phone call, and say, hey, look, you show up before 10 o'clock. he is going to yell at you and he is not going to participate. But you show up after 3, he is the nicest old man. You can say those kind of things. Yeah. That is stuff you can't write down, but information that often gets lost between settings. And maybe that therapist wastes 2 visits getting canceled or losing opportunities to intervene on that really critical post-hospitalization period.
Yeah. Yeah, I would definitely agree with that, and you hit the nail on the head for me. I mean, even today, just a similar situation that could have been prevented for sure in terms of cancellations. So I just want to thank you all for taking the time, having a beer with me, and just talking about your work in this really awesome article and being able to talk about this on a podcast. So hopefully more people can hear your all's perspective and some of the research that you did, because this stuff is very impactful. And practical and useful. I mean, even for people like me, tomorrow I can take a lot of these things and be aware of how it can impact readmission rates. So I want to thank you for that. And I want to give listeners opportunity to ask you questions if they have any. Kyle, we'll start with you first. What's the best way to hit you up on the internet? We can do Twitter handles. That's a favorite around here.
Yeah, if anyone wants to tweet any dissent or questions, they can find me at Dr_Ridge_DPT, and I'll be more than happy to engage in that route. And obviously, my and our gratitude for hosting us, and I would encourage everyone to keep an eye on Jason's research, because he's got a lot of things in marination, as it were, and is got a lot of really forward-thinking, innovative ideas and manuscripts and studies that will be coming forward in the next couple of years. So
yeah,
I imagine he might be a three-peat on your podcast.
I think so. So. What about you, Jason? Where can people get a hold of you?
So Twitter as well. I have substantially upped my Twitter presence since the last time I was on your podcast.
You have. Congratulations on that.
So I've actually started to try to engage with people positively as much as possible, and join some of these great conversations that are going on. So other therapists with dissenting or mostly complimentary awesome opinions of our podcast can go to at JRAY Falvey, so J Ray Falvey. And I usually kind of follow the same trends as Dr. Ridgeway on a JV level. So
yeah, and if anyone needs any fashion advice in terms of recommendations for shirt stays that are functional and do the job, as well as good socks, these 2 gentlemen are the ones to contact via Twitter. So once again, fellows, I appreciate your time, and thank the people at Cerebral Brewing for hosting this podcast as well out there in Colorado. And until next time, I'll talk to y'all soon.
Thanks, Dustin.
Thanks, man. That was awesome.
Hit me. I want to thank you for listening to this podcast. The show notes and much, much more can be found at seniorrehabproject.com. I want to encourage you to go there so you can join me and many others in the movement that's changing the face of geriatric rehab. Just go to seniorrehabproject.com, click join, and you'll be able to get access to our private Facebook group, which can basically serve as your virtual mastermind group. You'll get a short and sweet monthly email from me with useful links for you and your patients. And lastly, you'll get 10% off your first purchase from the Senior Rehab store. So all of this can be found at seniorrehabproject.com. And until next time, my friends, do not forget to stay funky.